My name is Caroline Stubblefield. I'm a nurse practitioner student at Auburn University. My subject is Candidiasis. Candidiasis is a fungal infection caused by yeast. There are over 20 different species that can cause the infection in humans. The most common is Candida albicans. Yeast infections can occur in the oral, vaginal, bullatus, skin folds, peronchia, which is the fingertip, and the subungual areas, which is fingernail. Yeast is part of the normal flora in the GI tract and oral pharynx. The overgrowth of the fungus is what causes the infection. The infection can occur at any age and gender patient. It generally causes a treatable infection. However, given the right environment and host, it can be deadly. Those who are at the highest risk for developing an infection are immunocompromised patients, those with diabetes mellitus, those on corticosteroid treatments, one who has received a bone marrow transplant, those on chemotherapy, and parenteral feedings. For this video, we will be focusing on vulvovaginal candidiasis. Vulvovaginal candidiasis is an infection of the vulvar skin and the vagina or both. It is most commonly caused by Candida albicans. Patients who are at risk for vaginal yeast infections include the aforementioned risk factors as well as those on broad-spectrum antibiotics, pregnant women, spermicide users, and being in the luteal stages of the menstrual cycle. They can also have no precipitating factors. There are some questions that are important for the nurse practitioner to ask his or her patient. One would be to ask about pruritus, vaginal discharge, odor, dysuria, dyspareunia. It's important to know that 50% of women have had a yeast infection by the time they reach 25 years old, so it's very common. 90% of these patients present with vulval vaginitis have pruritus, and many patients will have a cheesy, foul-smelling discharge. Next, you should ask, have you had any symptoms similar to this in the last year? Uncomplicated yeast infections would be defined as less than or equal to 3 per year, whereas complicated would be greater than 3 per year and may indicate an underlying unresolved issue that needs to be addressed. Next, you should ask about predisposing factors like pregnancy, steroid use, antibiotics, dietary intake, comorbidities, estrogen products, spermicides, douching, and feminine hygiene products. Patients with predisposing factors are more at risk for complicated vulvovaginal candidiasis, and patients that try to treat themselves are at risk for unresolved infections, and that needs to be addressed. On a physical exam, the practitioner will examine the vulva for erythema, edema, and excoriation. This would be an indication that the infection is irritating the area. A pelvic exam could be done, and if the vagina is erythemic, has white patches, malodorous, it is an abnormal finding consistent with vulvovaginosis candidiasis. Diagnosis is possible without a specimen collection and can be made by history and examination. However, if a pelvic exam is done, it can be included, and it allows for a specimen to be obtained, and a wet prep should be performed using saline and a 10% KOH solution. Using a microscope, one would visualize hyphae. The pH remains normal, which is 4.0 to 4.5, and the specimen could be sent for a culture as well. For the treatment of uncomplicated vulvovaginal candidiasis, there are over 9 over-the-counter intervaginal regimens available. They are applied as cream, suppository, or ointment and last from 1 to 14 days. They are 80 to 90% effective. An example of these medications are the azoles, AZOLES, like miconazole. There are 5 intravaginal medications that are available by prescription. Nystatin is one of these medications. And finally, fluconazole or diflucan is an oral single-agent tablet of 150 milligrams. That means you take it one time, and it obviously promotes medication adherence due to the one-time dose regimen. The infection is expected to resolve an uncomplicated yeast infection. For complicated vulvovaginal candidiasis, treatment of the acute attack followed by remission therapy is appropriate. You would use the intervaginal agents for 7 to 14 days or the diflucan every third day for 3 days on days 1, 4, and 7. For remission therapy, diflucan could be prescribed at a 100 to 200 milligram PO weekly for 6 months. And it should be noted that 30 to 50% of these patients will have return of symptoms after treatment has stopped, so they're just going to need continuous treatment. For non-albicans yeast infections, a referral to an infectious disease specialist would be appropriate. In another instance where a referral would be appropriate would be the special consideration patients of the HIV or the immunocompromised who just have complicated after complicated vulvovaginal candidiasis. Patients should be educated about keeping the skin clean and dry. This will create an environment that is hostile to yeast overproduction. Diabetics should keep a tight control over their blood sugar because yeast infections grow in an environment where people have high blood sugar. A patient should be instructed not to use scented soaps or bubble bath and stop drinking sugary drinks. For recurrent yeast infections, consider treating the partner for Balantis or using condoms during intercourse so that the partners do not continue to reinfect each other. Patients should eat yogurt and that contains a lactobacilli and will help maintain the normal flora of the body. And they should wear cotton underwear and loose-fitting pants, and they should not stay in wet swimsuits and stay out of hot tubs. This is a very common problem in the primary care setting, and so knowing more about this will help you be a better nurse practitioner. Thank you.